Hi everyone, in this video session I am going to discuss with you why there is a rapid development of microvascular complication among Indian diabetics when compared with Western patients. One of the biggest public health threat we are going to face in the coming years is complications related to diabetes. Now, India is considered as the diabetes capital of the world, with number of diabetic patients going to hit an alarming mark of 69.9 million by 2025 and 80 million by 2030. And also there is an increased incidence of diabetes at a younger age. Now we are living in an era where longevity or life expectancy is more because of modern healthcare facilities. So all these new young diabetes are going to live a long way, and they all are going to, most of them may develop microvascular complication. And the sad reality is Indians develop microvascular complication at a higher rate. There is a rapid development of microvascular complication when compared with Western population. So I am going to discuss the possible reasons for this rapid development of microvascular complication. One is late diagnosis of cases. The screening programs or screening tools for detecting diabetes mellitus in India is only in the nascent stages. Even if a patient is diagnosed to have diabetes today, he or she may be diabetic for long years and it may be undetected. And these years of undetected diabetes may have significantly affected the microvasculature. Second is poor glycemic control in the initial years after the diagnosis of diabetes. After we diagnose a patient with diabetes, many have a tendency to skip medicines, irregular treatment, or even switch to alternate systems of medicine because the newly diagnosed patients find it very difficult to digest the diagnosis, and they try other methods, other ways to avoid medicines for diabetes. UKPD study and DCCT study have demonstrated that if the glycemic control in the initial years after the diagnosis of diabetes is good, the risk of microvascular complications in long run will be significantly less. But if the glycemic control in the initial years of the diagnosis is poor, even if the patient have a better glycemic control in the later years, that will not give him much advantage, and the patient is at higher risk to develop microvascular complication. So the initial years after the diagnosis of diabetes is a crucial years, or we can consider this as golden years, where we need the best or optimal glycemic control to prevent microvascular complications in long run. But the sad reality in our part is we diagnose a patient to have diabetes. The patient, if the patient needs to take medicines, patient tries to avoid the medicine, go to some alternative systems of medicine, or skip medicines, or do not come for regular follow-up. And these golden years, the patients waste the advantage of these golden years. Next reason could be lack of incorporation of HbA1c testing in the routine diabetes care. We all know that HbA1c gives the average blood sugar value of last 3 months, and HbA1c is considered as a gold standard test all around the world for monitoring glycemic control. But in India, usual practice is to check the blood sugars alone, either random blood sugar or fasting blood sugar or postprandial blood sugar. HbA1c can be grossly deranged even if fasting blood sugar and post-breakfast blood sugars are in control, because in India, lunch or dinner is usually the largest meal, and post-lunch and post-dinner blood sugar surges will not be captured in the routine fasting blood sugar and post-breakfast blood sugar values. There was a survey called DEDICOM survey, that is Delhi Diabetes Community Survey, and here they surveyed urban diabetes from middle and high income group in Delhi, and the results was very disappointing. Only 13% of the respondents had undergone HbA1c testing, and only 21.7% has had ever heard of HbA1c testing. So that means HbA1c monitoring is not popular in our part. So we are not following the gold standard monitoring protocol. Next reason could be late initiation of insulin therapy. There is some point during the course of diabetes, type 2 diabetes, where patient can no longer be managed with oral antidiabetic drugs. Patient needs insulin to get the blood sugars fixed. But most of the time, insulin initiation may not happen. This could be because of financial constraints. Insulin will be definitely more costlier, needle phobia among patients, and also fear of bad reputation among physicians. Bad reputation among physicians means patients do not like physicians who start insulin. Patients usually prefer physicians who manages his or her diabetes with tablets. So to get more patients, to avoid the bad reputation, many physicians are reluctant to initiate insulin even if indicated for the patients. So what we can do to prevent this rapid progression of microvascular complication? Only thing we can do is increase the awareness among public and among healthcare individual staff. Thank you.